In looking at these two personality disorders, the schizoid, which is more like zoided out in a world of your own, and the schizotypal, which is a type or more like the type of schizophrenia. In the schizotypal, we very often have what we call ideas of reference. An idea of reference means that a person is caught in a particular idea, and that's different than a delusion of reference or delusions of reference. An example of delusions of reference would be seen in schizophrenia. Like, for example, everybody's out to get me. Everybody's out to get me. Look, did you hear that show? Yes, that guy was talking about me. He's out to get me. And those people over there are out to get me. And every time I go someplace, they're wandering, they're watching me, everyone's out to get me. That would be delusions of reference. That's different than an idea of reference. An idea of reference would occur in a personality disorder such as the schizotypal. And what it has to do with focusing on a specific item or a specific idea. An example might be, I'm useless, I'm worthless, nobody's ever going to love me, and Jack Kevorkian is going to find me and take me out. He's going to just end my life because he takes care of useless and worthless people. He'll come and get me. So the fear then that this person has is not of everybody coming to get her, but of specifically Jack Kevorkian coming, because she's afraid that he knows who's useless and who's worthless, and he helps them to end their lives. So he'll come and offer to end hers. It's just focusing, it's not a delusion of reference, it's an idea of reference. I'm useless, I'm worthless, Jack Kevorkian takes care of useless and worthless people, so therefore he will come and take care of me. Now, I'm not saying that's true, I'm just saying it was a particular example for a client. Another one might be, I have to have my lucky locket, because if I don't have my lucky locket, I can't go out. My lucky locket gives me strength, it gives me power, it makes me feel better. I can't leave without it. So in that case, what you've got is somebody whose idea is focused on a specific locket or a lucky coin, and they can't leave the house without it, or they can't function without it because they have to have it. That would be an idea of reference. Another idea of reference would be, here's one for you. My mother died of a heart attack, so therefore I'm going to die of a heart attack. I know it. My mother died of a heart attack, I'm going to die of a heart attack. And you can't tell me any different. Well, look, my mother died of a heart attack, so I know I am going to die of a heart attack. That would be an idea of reference, where you get a specific idea and you can't deviate from it. You can't, it's not that I'm afraid of everything, it's just that one particular thing, or the client's afraid of that one particular thing. Those are your ideas of reference. Make sure that you know the difference between delusions of reference and an idea of reference, and that generally the ideas of reference are more like schizophrenia, which occurs in the schizotypal type of schizophrenia, more like the type of schizophrenia, schizotypal or schizotypal personality disorder. Some of the other personality disorders that you might see on the test are what they call the cluster B, the dramatic, the emotional, and the erratic. That's your antisocial, borderline, narcissistic, and histrionic. Antisocial, basically that's the old psychopath or sociopath. The borderline personality disorder. Be very careful, because in that one you have a real instability of the self. Be sure to set clear boundaries and diffuse crises. That's critical. In the borderline, be sure to set clear boundaries and to decrease crises. Case example, this is a good example of how to diffuse crises and set limits. I worked with a client who has borderline personality disorder. Very often, you'll talk with social workers and they hate working with borderlines. And one of the reasons they do is because it's so problematic in terms of working with them. So what you've got is you've got someone who is afraid, basically, of where their boundaries stop and yours start. That's the borderline personality disorder. I worked with a woman who had cut her wrists, and basically she had cut her wrists so many times that it looked like elephant skin over and over and over and over again. Repeated hospitalizations, she would attempt to harm herself and constantly ended up in the hospital. Anyway, one of the things too with borderlines is very often they have a real hard time telling where they start and you start. So they become yours. They won't see anyone else. They want to see you and only you, and they won't see anyone else. Well, this borderline came into the emergency room, and we had a contract that we had done to diffuse crises. And basically, if she felt suicidal, she was to come to the emergency room, be screened. If she needed to be admitted, she'd be admitted, and then I could come see her once she was admitted. So that was the plan. I mean, it was a very clear plan. So she comes to the emergency room, and she tells them that she's suicidal. And they say, okay, well, we'll get someone to screen you. And she said, oh, no one can screen me but Dr. D. Dr. D is the only one who knows anything. No one else can screen me. You better go get Dr. D. So the nurse has got a busy emergency room, and here's this client giving her a hard time. So she says, all right. So she calls me on the telephone, and I'm in session. I'm not screening that day. I'm up in the unit. So she calls me on the unit, and she interrupts my session, and she says, look, so-and-so's down here. She thinks she needs to be admitted. She's feeling suicidal. She won't talk to anyone but you. Will you come down here? And I said, listen to me. One of the things that we have to do when we work with borderline clients is we have to set clear boundaries, and we have to diffuse crises. She knows the plan. Please remind her of the plan. The plan is to have somebody screen her. If she needs to be admitted, I'll see her on the unit later today. Tell her I am here today. So the nurse starts to tell her this, and I'm on the phone and I can hear it. And so she starts to tell her exactly what I told her. My client is saying, oh no, you don't understand. I'm really sick. I am really sick, and I am really suicidal, and I need to see her. I don't think you understand. I need to see her. So the nurse hangs up the phone, and about 10 minutes later, she calls me back again. And she says, you have to come down here. She's tearing up my emergency room. I don't know what else to do. And I said, listen to me. Every time you call me, she sees you calling me, and you're actually, creating a problem in terms of this contract. Now, please, this is the contract we have. Please tell her this, and let me listen on the phone as you do it. So she did. She told her. All right, then she hangs up the phone. Well, my client wasn't taking that for an answer. And so she went into the bathroom of the emergency room, and there happened to be a lock on the outside of the bathroom door. She locked herself in the bathroom, just happened to have a disposable razor with her, slit her wrists, dripped the blood on a paper towel, slid it under the door, and started yelling, I'm dying in here, I'm dying in here. Well, the nurse was hysterical because she had the patient, she had the blood, she was locked in the bathroom, she's claiming she's dying, she didn't know what to do. So she calls me on the phone, she says, you have to come down here immediately, she's bleeding to death in the bathroom. I said, listen to me. And I thought about this for a minute, because I don't think that my client would have hurt herself. I mean, I don't think she wanted to die. I think she needed the attention. But you worry that they cut themselves too deep, that it really does create a problem. But I thought, if you're ever going to cut your wrists, where's the best place in the world to cut them? In the emergency room. I mean, you can't get any better than that. And she's already done it. So now let's get her out and see what we need to do. So I said to them, I said, we really have to stick with this, because this is critical to set limits for this client. What I want you to do is, I want you to remove the door from the bathroom. The nurse was livid. She hung up on me. She was so angry. She got the janitor, and they removed the door. They were all upset with me. They didn't talk to me in the emergency room for weeks after this. But what happened was, when they got her out of there, I don't even think she got 2 or 3 stitches. It was a pretty surface cut, a lot of blood, but surface cut because it was a razor cut. And then they were so aggravated with her, they admitted her. They admitted her to the unit, and so I went to see her on the unit. And when I went to see her on the unit, she wouldn't talk to me. And the reason she wouldn't talk to me is she said that, well, first she told me why she wasn't going to talk to me. She said, I'm not talking to you because you didn't care about me, you didn't care about what happened to me, you didn't make sure I got what I needed. And I said, listen, let's get something straight. We had a contract, and you violated it. Here was what the plan was supposed to be, and you didn't follow it. And these are the circumstances that resulted. Now, I have other clients to see, so either you talk to me now, or I will come back at the end of the day, and I don't know how much time I'll have then. I'm making it very clear to you what the guidelines are here. And so she said, well, how could you do this to me? How could you leave me? Da, 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 da. So I just said, okay. And I started to walk away. And she said, all right, I'll talk to you. Anyway, we were able to talk. When you work with borderline personality disorders, it's absolutely critical that you set clear boundaries, clear guidelines. You make sure that you diffuse crises and that you work on those issues. Another example of a different personality, narcissistic, grandiose sense of self-importance. And one of the criteria for narcissistic personality disorder is a lack of empathy, clearly a lack of empathy for others. In narcissistic personality disorder, they believe they're the center of the earth and nobody else matters. You know, nobody else is important. It's their needs. They wrote the rules. You know, they are the center. That's narcissistic. There's also what they call cluster C, avoidant personality disorder, dependent personality disorder, the obsessive compulsive personality disorder, which is the perfectionism, the inflexibility, and passive aggressive personality disorder, which was dropped. All right, it's more like a pattern of procrastination. It was indeed dropped, and it is not a personality disorder anymore, but it used to fall in that category. The last section in this piece is talking about selected other conditions that may be the focus of clinical treatment. Remember when I talked about Axis 1 and I said those V codes that are not attributable to a mental disorder? That's this part here. It's called selected other conditions that may be the focus of clinical intervention. And that's your academic problems, childhood or adolescent antisocial acts, borderline intellectual functioning, malingering, occupational problems, bereavement. These are where all of the V codes would fall, and they are coded on Axis 1. The only one coded on Axis 2 is borderline intellectual functioning. That's the only one that would be coded on Axis 2. There's one other area that I wanted to cover in this section that I wanted to talk about, and that's not directly talked about in the DSM, but it really needs to be discussed here, and it's looking at AIDS and HIV disease. Basically, AIDS is definitely reached what they call pandemic proportions. Epidemic means it's across a continent, but pandemic means it's everywhere, every place, every continent, and it's pandemic. They also say that approximately 12 weeks after infection, you can actually get a positive test. So many people, once they have been infected, they're not aware of whether or not they have the infection, and they may be very uncomfortable, you know, in terms of trying to figure out if they have it or not. It does take a while to get a positive test. And the sad part is the disease can be transmitted very soon after infection. When I first started teaching this course, we had talked about the possibility of us having 1 million cases of AIDS in the United States. And then before I knew it, it was 2 million, and now it's 2.5. The numbers are going up in terms of the different cases of AIDS. And what they're saying is the 3 top states are California, used to be New York and Florida, now it's New Jersey and Florida. Those are the top 3 states for different cases of AIDS. In terms of when somebody has AIDS and when they don't, basically a T-cell count, T-cell counts are your protective factor within your body. When a T-cell count falls below 200, so T-cell count falls below 200, you are susceptible to opportunistic infections. That's when HIV status becomes AIDS. So T-cell count below 200, actually it's 200 or below, and you become susceptible to an opportunistic infection, that's when you have AIDS. That's when AIDS is diagnosed. So that's when that happens. When somebody comes in to see you, it's absolutely critical that you send them out for typing or staging so that we can know where they are, because a normal T-cell count, it depends on who you read, can be anywhere from 400 to 500 to 1700. So we want to know where somebody is in terms of the staging process. We can also tell with a T-cell count And by the way, the level of the T cell count can help to tell who infected who, or who got it first, by how far the disease has progressed. The other thing is that we can tell by different strains of the virus. For example, there was the case of Kimberly in Florida. Kimberly was the first person that was ever documented who went to a dentist and got infected by the dentist. So she was the first person who was a healthcare recipient who was infected by the healthcare provider. Basically, she went to the dentist, she came down. It was a very viral strain of the disease. She didn't have the typical risk factors. She came down with the disease, and he died within 3 years. She died within 3 years of the same viral strain of the disease, which was very unusual. Most people can live 10 to 15 years with AIDS, 10 to 12 years. So it was very unusual that this thing was so fast. But she was the first case where they actually looked at that. And by the way, that's one of the reasons why we use universal precautions. And we always make sure that we protect ourselves from body fluids and those kinds of things when we're working with people who are HIV positive. If you're working with a mother who may suspect that she's HIV positive, it's really important that the family get counseling, the husband and the wife or the couple, because sometimes it takes quite a while, and actually they say it can take up to 15 months, even with some of the newer tests, before you can be really sure whether or not the baby is infected. And what they'll do is they'll test the mother if there's a possibility, and then what you want to do is recommend that she get on medicines or some kind of a HIV cocktail where she'll get in and they'll do it. And what the studies have found is if you're more likely to have the cocktail, you're less likely for the baby to be positive. So they're more likely to test and then give the cocktail to the mother, especially if she's HIV positive. Well, if she's HIV positive or AIDS. So the baby would be less likely to be born that way. Remember that if you are taking, or if you get a needle stick, you will receive very often medications as a precautionary event. Here's a sample question that has shown up that a lot of people have struggled with that I thought we could talk about a little bit. It says, the social worker suspects that a client on her unit is having sexual intercourse with another client on her unit. It's against the policy or agency policy to disclose information to clients on the unit about other clients on the unit. What should the social worker do? Probably the most important thing to remember when you're working with any client is that we educate, advocate, facilitate, and intervene. Meaning that before we advocate for a client, we would educate the client to advocate for themselves. So we educate the client so they can help themselves. Then we would advocate for the client. So in this case, what would we do? Tell the client that the individual he is having sexual intercourse is HIV positive. B, be sure the client is aware of HIV and the risk of having relations with someone who is HIV positive. C, tell the agency administrator about the situation. Or D, violate agency policy to protect your client. 4 choices, A, B, C, and D. What I suggest you do is pick your 2 choices. And your 2 choices are going to be tell the client that the individual he is having sexual intercourse is HIV positive, and be sure the client is aware of HIV and the risk of having relations with someone who is HIV positive. Now, what would you do? All right. Would you tell somebody that somebody else is HIV positive before you know whether or not they know what HIV positive means? So even though it might seem like common sense, what you want to do is you want to educate the client first. So you want to make sure that the client knows what HIV positive is and what AIDS is before you go telling them anything. And by the way, I'm not so sure I would tell them. But even before you move to answer A, you should do B. So B is the answer. It's between A and B is the better answer. That's the one that involves educating the client. The other thing I wanted to mention is assessing danger to self or others. Whenever we're in a psychotherapeutic relationship, we need to make sure we know the difference in terms of assessing danger to self or others. For example, when we work with clients, there are two things. There's something called ideation, and there's something called intent. Ideation is the idea to harm oneself. Intent is the plan to do it. Whenever you work with a client who has an idea but no concrete plan, you can do what we call a no suicide contract. It must be in writing. The no suicide contract must be in writing, no verbal contracts, and they must be willing to contact. What you say is, I, client's name, agree that I will not harm myself. If I feel as though I could harm myself, I will call. You put the number of the facility and the name and the address. Make sure it's a 24-hour hotline, or make sure it's an emergency room of some type. Do not put your name, do not put a family member's name, because you got to have the 24 hours. And then have it witnessed. Make sure it's in writing. If they tell you that they would indeed harm themselves and they have a plan, you should not do a no suicide contract. The first thing that you should do, if that's what it says, all right, so first I assess. It depends on what the answers are. First I assess, but then I would immediately seek hospitalization. I would try to seek hospitalization for the client, because that's critical. All right, if they're a danger to self or others, I'm going to seek hospitalization. That's intent. And particularly in this case, it's a danger to self, so I seek hospitalization. In ideation alone, I could indeed do a no suicide contract. Make sure it is not verbal. It must be in writing, should be included in the record, and it should not be where they're calling you or a family member. That's the section that we've just covered on looking at the psychotherapeutic aspects, taking into account the DSM and going through it. What I'd like to do now is just review a couple of sample test questions to give you a flair for working test questions in this area. Now, in this section, there are sample test questions for you to do. There's also sample test questions in the back of the book that I'd like you to take a look at. So let's just start. I want to do just a couple. Let's look at the sample assessment questions. And the first one says, an individual with obsessive compulsive personality disorder. Okay, so what do we got? Obsessive compulsive personality disorder is not likely to display the following characteristic. A, stinginess, B, indecision, C, perfectionism, or D, hallucinations. We've got four choices, all right, and not likely. So there's going to be 3 yeses, 1 no. Stinginess, obsessive compulsive, yes. Indecision, yes. Perfectionism, yes. Hallucinations, no. That's your answer. So your answer is D. Go ahead and read through some of the other questions and take a look at it. Let's look at number 4 though, right underneath it, as we'll do that one and then we'll move on. L is brought to therapy by a relative. L claims that she is afraid to leave home, and when she tries to leave the house, her heart begins to beat rapidly and cold sweats develop. The best preliminary diagnosis for this client is A, bipolar disorder, B, generalized anxiety disorder, C, panic disorder with agoraphobia, and D, obsessive compulsive disorder. Basically, what you've got is what's the preliminary? Okay, she's afraid to leave home, and when she tries to leave home, her heart beats rapidly and cold sweats develop. The best preliminary diagnosis is, all right, that to me sounds like, let's rule out. We could do bipolar, no. Generalized anxiety disorder, yes. All right, that definitely sounds like a possibility. Panic disorder with agoraphobia. Okay, that's a possibility. Obsessive compulsive disorder, no. So I say it's between B and C. Now, she's afraid to leave the house. Okay, that to me sounds like agoraphobia. Generalized anxiety disorder is the worrywart with multiple symptoms. So really, that is B, all right? That is not the answer. It's between B and C. C is the best answer. So on page 19, question number 4, C is the best answer. Panic disorder with agoraphobia. Now what I want you to do is turn to the back of the book as we end this section and just go over a few more on page 110 in the back of the book. Now, these are the test questions that have been written directly by the testing service, and I just wanted to go over a couple of them with you just so that you can get a feel for them. This one's off the advanced exam on page 110. Which of the following factors is not used in diagnosis using the DSM-4 framework? So what it's saying is 3 yeses, 1 no. Which is not used? Okay, physical disorders? Yes. Does anybody remember axis 3? Good. Psychosocial stressors? Axis 4. Clinical syndromes? Axis 1. Lowest level of the functioning in the last year. That would be axis 5, except it's not the lowest level, it's the highest level. So the answer then is D. Please, this is what I mean by tricky. You may be tired, and that kind of stuff may catch you. So watch it, go slow, and break it down. How about number 2? Schizophrenia differs from dementia because A, schizophrenia is an affective disorder. By the way, schizophrenia is not an affective disorder. Bipolar disorder, major depression, cyclothymia, dysthymia, those are your affective disorders. Schizophrenia is a psychotic disorder, so that can't be true. All right, that doesn't make sense. The origin and cause of schizophrenia is unknown. Now that's true. All right, that's definitely true. The etiology of dementia is generally known or presumed. Very often we do know what causes it. We know it's the plaques, the tangles, the strokes. We do have an idea. So I'd say maybe. Schizophrenia involves periods of short-term memory loss. Schizophrenia has nothing to do with memory loss. Nothing. Dementia involves disorganization and a break with reality. All right, dementia involves disorganization and a break with reality. No, that doesn't make sense. The onset of schizophrenia, this is choice D, the onset of schizophrenia is early in life. Well, what does that mean? Age 1, 6 months, 9 months? If it said early in adult life, I'd say yes. Be careful. Be careful not to read something in. So that has to be a no. And dementia affects the elderly. Sure it does, but it could affect anyone who has the particular problem. So I'd say out of those choices, it's between, actually B is best. B is the answer. And you have to start going in and looking, and I'd say it's between B and, there is no second choice on this one. It really is B. B is the most clear. The clinical exam. A clinical social worker asks a young child during an assessment interview, if I asked your parents what they think of you, what would they say? The social worker is assessing the child's A, dependence on the parents, B, reality testing, C, conscience, or D, self-concept. I'd say take it down to B, reality testing, or D, self-concept. Those are the 2 choices. And that is exactly how you measure self-esteem and self-concept. So the answer is D. Intermediate exam. According to the DSM-4 criteria, which of the following symptoms is most prevalent in persons with a major depressive episode? Now, what was the major depressive episode? Last 2 weeks, and the 2 primary signs were eating and sleeping. 2 weeks, eating and sleeping. So what's the most prevalent? Inflated self-esteem, sleep disturbance, hallucinations, or a negative view of the future. I would say it's between, let's see, inflated self-esteem and hallucinations are out. So it's between B and D, and B is definitely the answer. So that's better. So B, sleeping and eating. B is sleeping. So B is the answer. Hello. In this section, we're going to look at direct and indirect practice, communication, and professional relationship issues. Now, this section actually has several sections blended in. And the reason for that is it's so hard to separate out a communications issue from application of a models or a direct practice issue. So they're all included in the same section. In the direct practice area in particular, like pretty much just going over the models and the foundations of those, your exams are anywhere from the basic exam all the way up until the clinical exam. You're looking at anywhere from about 23% to about 19%. This also includes communication issues, where you're looking at anywhere from about 7% to 9%. And this is relationship issues as well, anywhere from 4% to 8%. There's also some overlap between this section and human growth and development as well. And you'll notice that some of the theories that we cover in this section are human growth and development theories, because that's where they are. I mean, that's what they are. When we talk about Freud, that's a human growth and development theory. Why do we need theory? No matter what level of the exam you're taking, or no matter what area of social work that you work in, as generalists and as specialists, you have to have a good theoretical foundation. Social workers feel very strongly about that. We feel that you have to have theory. You can't just use a model without understanding the theoretical foundations of that model and what are the requirements of that model. Theory allows social workers to predict outcomes. It allows us to look at the consequences. It helps us to notice what might be considered an unanticipated relationship. For example, if I don't know anything about a family that I have in therapy, and I have a mother, I have a father, and let's say I have a child. I don't know anything about these three individuals. But because I understand theory and because I understand communications theory, I can apply that theoretical foundation to any individual or any couple or any family that I work with. For example, because I know that there's three people in this triangle, I know that something is going to happen. And what's going to happen almost always is, in terms of communication, two people are going to join together against the third. Now, for the most part, what two people do I want to join together against the third, or to come together united against the third? In most cases, I want it to be the mother and the father, to present a united front or a united action plan to deal with the child. So by understanding communication, I can predict factors like that. I can also, with theory, it provides a baseline for where to begin, where to start, how to pull things together. It also provides professional recognition. As social workers, what we do is so important in terms of looking at that individual from not only an individual perspective, but from a theoretical foundation. That's part of the practice skills that we bring. In terms of theories and practice are comparable. Regardless of what model you use, there are certain things that make them comparable. For example, the value base. What we believe in social work is that all models, no matter what model you use, must have a consistent value base. And in that value base, which we've talked about in other sections of this tape, we believe in worth, dignity, non-judgmental. You know, we want to make sure that our clients
are treated with the worth, the dignity, and the respect that they deserve. We also believe, in terms of the assumptions and the theoretical base, that most models actually look at different theories and guidelines and theoretical concepts. And most of the time, in almost every model, what we focus on is the person in environment, or the person in situation. One of the things that I always say when people say to me, you know, what's the difference between social work and sociology, or social work and psychology, or social work and anthropology? What do you and social work do differently? What I always say is that in anthropology, particularly cultural anthropology, you study the culture of an individual. In sociology, the emphasis is on the society. In psychology, the emphasis is on the individual. But I see social work as the bridge. And what it bridges is the person to the environment, or the person to the situation. Because if we don't take that into account, then the person's situation or environment gets lost. And that's what makes what we do so unique. I'll never forget, one time I was in court working as an expert witness, and a judge asked me, he said, you know, tell me something. What exactly does a social worker do that's different than everybody else? And I said to the judge, I said, well, let me give you an example. I'll never forget when I worked with a young man who was in a substance abuse program. He had gone through a 30-day program. He went through the program 30 days, successfully completed the program, did beautifully, discharged him to the community. Within a week, he was back. Same thing, 30-day program, worked beautifully, discharged him back into the community. Within less than a week, he was back. This happened 4 times. Do you know how much money that cost the society, that cost the, the program? Basically, with the regeneration of coming back and coming back and coming back, his recidivism rate was incredible. I was called in on the case and I took a look at it. And you know what I found? Very simple. When I went in and looked at where he was being discharged to an address. When I hunted down the address that he was being discharged to, it was the local bar. He really didn't have an address. He was using the local bar. So he was going to the local bar when he was discharged. And when he went to, by the way, his check used to go to the local bar, and they would cash it for him regularly. But they always had a policy, and the policy was, you have to buy something in order to cash a check. So if it's between beer and nuts, which one are you going to pick? Anyway, to make a long story a little bit shorter, is what we had was an individual who was constantly being sent back into the system because nobody looked at the situation. Nobody was looking at the environment. And after I got him placed into a group home and got his check away from that particular, bar and sent to the group home, he was not readmitted. And at least he was not readmitted for a year, the year that I kept in touch with him in terms of case management. So look at the savings that occurred and look at the relationship. And that's social work. Social work historically has done that. We've been not only in treating the individual, but treating the individual in regards to the society. How does it relate to the society? In terms of the practice structure, most of the models are what we consider linear. Now, linear simply means, if you think of linear, you can think of a line. So what we have is a problem, a solution, and it's a linear progression. Many of your models are considered linear. For example, we have the problem-solving model, which is considered linear. Or we have behavior mod is considered linear. Or cognitive behavioral is considered linear, where you're looking at problems linked to solutions. There's one particular model that is not considered linear, and it historically has been considered circular, and it's called systems theory. In systems theory, what you have is you have a problem, you have a solution, and it is linked through feedback loops that constantly go back and forth and back and forth. That's your problems, solutions, and feedback loops. So most of our models are linear, but there are some that are actually circular. In terms of conceptualization of the client, we have historically used the terms micro, meso, and macro. Micro, meso, and macro. Micro is where we have a focus primarily on the individual, the couple. Sometimes families are included in micro, but usually it's the individual or the couple is more of a micro perspective. We have the meso perspective, where you have an individual, but that individual is part of a bigger system. So the meso perspective would be the individual and the environment. Or you could look at families. You could look at communities, individuals as parts of communities. Some of the textbooks also say that meso includes administration. Some don't stress that, but that's a possibility. And then the last one we have is macro. And macro is representative of a much larger area. Macro is social policy and social change. And very often in macro, we're looking at the big picture. What is the big picture? Rather than looking at the smaller pieces. Social legislation, social action, social change. And macro is actually much harder to affect changes in because those changes take long term and they're much bigger than working with just an individual. So micro is where your focus is primarily on the individual or the couple. Meso, where you're more of an environmental focus or on the families or the communities. Or you can do macro, where the emphasis is on social policy and social change. Those are the three major areas. The one that we are the weakest in, and will probably always be the weakest in, is macro. And that's because of the long-term policy changes that are required. Even though we tend to be stronger in micro and meso, we can never affect or actually forget the importance of including that macro perspective. You always want to use or include in any type of therapeutic environment the macro. We also believe that relationships are important. For example, whether it's behavior modification or if you use Carl Rogers client-centered therapy, you have to have a good relationship with the client because relationships build rapport, and rapport is very often the foundation for change. We also believe that individuals are capable of change and that what happens to individuals is not the complete fault of the individual. Many times individuals are influenced by the society, by the way that they are raised, or the situational factors that surround them. In terms of looking at relationship between qualitative and quantitative, we say that qualitative research, whenever I think of a qualitative approach, I think of the show Cops. Bad boys, what you gonna do? You remember at the beginning of that show where they go through and they show, they basically show you everything. And they say during the show, they say, please remember that nobody is guilty until proven guilty in a court of law, because what they're doing is they're showing you the big picture. The idea is for you to look at the big picture and then to make assumptions from the big picture. Quantitative research, on the other hand, is different. In quantitative research, what you would do is look at the little picture and then make assumptions from the small to the big. So you want to generalize out from the small sample. For example, I worked with a woman one time who was afraid of snakes. And so I actually worked with her on getting over the fear of snakes with a technique called systematic desensitization. As we worked through that technique, I tried to take that and generalize it to other clients, to other problems. And I tried to control it as much as I can to do that. In the qualitative, you go from looking at everything to the small, where in quantitative, you look at the small and try to generalize to the big. In terms of validity and reliability, it's always important that you remember the terms validity and reliability for the test. The way that I remember them, if it helps you, is I always remember that validity starts with a V and stands for the value of what you're doing. Reliability starts with an R, and the words that define reliability are replicate, random error, and repeat. That's what reliability is. Reliability means that you get the same thing over and over and over again. Within a certain degree of error, you're going to get the same thing. That's reliability. Validity, on the other hand, is that it measures what you want it to measure, or it is considered valid, or the value of what you're doing. That's how you measure what you're supposed to measure. Please remember that a measurement can be reliable, meaning that you get the same thing over and over and over again, but it may not be valid, meaning that what you're doing is you're measuring the wrong thing over and over and over again. Know the difference between reliability and validity. A very good example of this is, what would this be? Reliability or validity? A social worker designs a measurement instrument, and she wants to measure depression in her clients. Yet the measurement instrument measures self-esteem. She continues to get the same or pretty close to the same scores over and over again. The social worker's greatest concern is A, the instrument's reliability, or B, the instrument's validity. It would be the validity, because you're getting the same thing over and over again, but instead of measuring depression, she's measuring self-esteem. That's the difference between the two. And by the way, that was a little bit of research overlapping in the models. What you'll see throughout this tape is that we are going to do that. We're going to have some overlapping criteria. And that's why the nice thing about the exam is it's an overall score. So you're going to see questions and you're never going to know exactly what area they're in. Like reliability and validity could be in the models section or direct practice just as easily as it could be in a research section. In terms of applying the specific social work practice theories and models, if we start with the oldest model there is, let's go back and look at the two that are usually considered the older cornerstones. And again, it's very open to interpretation, but it's just a good way to remember this. If you think about it, let's think about the functional school. The functional school. And then let's think about what we call the psychosexual schools, or the psychodynamics. The psychodynamic theories. In the functional theories, we're looking at people, and again, you don't need names, but this may help you. We're looking at people like Jessie Taft and Virginia Robinson, Otto Rank, and what they believed is it's very much a function of the agency. So what gives legitimacy in practice from a functional perspective? The agency. The agency is what gives you your legitimacy for what you do. A good example of functional theory. I'll never forget, one time I was working in an agency and I was training foster parents. And I'm an LCSW, so I can do marriage and family therapy, and I can do group counseling, and I can do couples counseling. And I had a couple come in for the foster parenting program. And they were actually really good for the foster parenting program, but they had some issues, some marital issues. Now, I could have done marital therapy with them. I mean, I could have worked with them, and I believe in a couple of sessions I could have helped them. But from a functional perspective, I was not allowed because my role was there to strictly train foster parents. So I had to refer them to someone else. From a functional perspective, the agency determines what services you provide. From a psychodynamic perspective, however, it's not the agency that determines what services you provide. It's actually the profession. So in this one, it's the profession. The profession determines what services you could provide. So if I was in practice for the profession, I could do anything based on my profession in terms of marital and family therapy, etc. I wasn't limited by the agency. Another difference between the psychodynamic models, which would be the old psychoanalytic model, which is Sigmund Freud, or the neo-Freudians such as Anna Freud and Erik Erikson. A big difference between the psychodynamics and the functional, or what they call the problem solving. The problem solving approaches are much more functional. What they believe is, under these functional approaches, is the whole concept of self-will. We believe, or the functional individuals, or the functional theories, believe in self-will. That you indeed can decide and that you can make decisions. You have capability of making those decisions because you have the self-will, or what would be referred to as some people as self-will or free will. The psychodynamic approaches, on the other hand, believe in the conscious and the unconscious. And actually, some of the neo-Freudians believe in something called preconscious. Preconscious is right below the surface. So it's like right there, and you can get to it, but it's not really at awareness. In these models, they truly do not believe, or they question, the level of free will. So free will then, in these, actually becomes questionable, because it's influenced by it's actually little or limited free will, because it's influenced by what is conscious, what is unconscious, what is preconscious. But those are more of your psychodynamic approaches. The other primary difference between these is that, again, the free will, all right, in this one, or limited free will in this one, and the free will in the functional. Another one is that individuals can make choices. You have free will and you can make choices. In this one, in the functional approach, it's very clear the choices that are made, that you can make choices and that you can act on those choices. In the psychodynamic approaches, choices can be done, they can be made. However, they're limited. And again, they're limited by the conscious, the unconscious, and all of those types of issues. That limits those. The functional approaches are usually, again, the main keys are the agency is considered the center, and that's where you get your legitimacy. In the psychodynamic, it's the profession. In this one, in the functional, you have self-will, which is considered free will. In this one, you have limited free will or self-will in the psychodynamic. You also can make choices in the functional, where you may not be able to make them in the other. In terms of some of the specific psychodynamic models, the most common psychodynamic model, or one of the oldest psychodynamic model, is actually a psychosexual model. It's a psychosexual model. And when we talk about psychosexual models, almost always we're talking about Sigmund Freud or Freudian models, where the emphasis is on sexual needs, sexual drives, and sexual impulses. one thing that you want to remember too, and we talked about this in Human Growth and Development, or we will talk about it in Human Growth and Development, is that when you go through the stages of development, this is a Human Growth and Development theory, when you go through the stages, if you get stuck at one stage, you will never fully develop to the stage above. So if you're stuck at one, you'll never fully develop to the stage above. And so it's very important, particularly when you're looking at these models, to realize that individuals must actually get through what is considered the primary conflict. In Freudian theory, or in psychosexual psychoanalytic theory, what you're looking at is he talked about 5 stages. We have the oral stage, where he talked about the source of satisfaction being the mouth, and they say that people who are stuck there are passive and dependent. And those would be examples of conditions, might be the nail biter, or the overeater, or the drinker, because they are fixated with the mouth. The second stage is the anal stage. And in this stage, the conflict is toilet training. That's basically what you've got to get past. People who are stuck in this stage, or who get fixated in this stage, are selfish, rigid, and stingy. Examples would be obsessive compulsive personality disorder, or obsessive compulsive disorder would be stuck in the anal stage. And by the way, that's why they say that all researchers analyze everything, as they're stuck in this anal stage, because they have to be so obsessive about everything they do in terms of control, control, control. In terms of looking at the next stage, it's the phallic, where the source of satisfaction with the individual is the genitals. At this stage, there are 2 primary conflicts that were discussed. One is the Oedipus complex. In the Oedipus complex, what you're looking at is a little girl, the little boy, who wants to have sexual intercourse with his mother. All right, that's what he wants to have, and he knows that it's wrong, or he knows that he's going to get in trouble for it, so he suffers from castration anxiety. That's where castration anxiety came from. Then you have the neo-Freudians, after the psychosexual approach, said that the same kind of thing can happen in girls as can happen in boys. And they talked about something called the Electra complex. The Electra complex is what happens with little girls, where the little girl is sexually attracted to her father. She wants to have sexual intercourse with her father. She fears that she will be found out. That's the Electra complex. And by the way, this is where the term penis envy came from. Because what they said is that a little girl can't have castration anxiety because she doesn't have the penis. And the penis was considered the center of all existence, so to speak. And so she would develop what they called penis envy. The next stage is latency, where children just basically learn about themselves, and that there's not much happening in that stage. The last stage is the genital stage, and that, according to Freud, had occurred at about age 12 and up. I personally believe that if Freud was here today, he would probably raise that age, because people got married younger, things happened at a younger age. Now we have a much longer adolescence. So young girls or boys are not getting married at 12. Now they're waiting until a much later age. But at that level, once you hit that genital stage, that's when you're capable of what they call mature genital love. That's when you're able to really love someone. Now, the idea behind these stages is if you get stuck at one level, you'll never fully make it to the one above. You can't make it to the one above it. In terms of personality, another thing that Sigmund Freud talked about, or actually that comes out of this psychodynamic approach, is the id, the ego, and the superego. From a psychoanalytic perspective, the id is your libido, your sex drive, the inner drive. The id is the inner sex drive or the libido. And when you hear the term libido, you're talking about somebody's sex drive. The ego is what they call the mediating force. And this develops in adults because that ego becomes critical in mediating the drives from the id and the superego and pulling them together. The other one is the superego. The superego is where moral development occurs. And it's actually in the superego that they say guilt is located. So if we were looking at a person with antisocial personality disorder, for example, they say that they don't truly understand guilt. They don't really understand it. So at that level, what you would be saying is that their superego development is impaired. Their guilt is impaired. The other thing in terms of the superego, if you ever see a question that talks about moral judgment and guilt, they're talking about the superego. A lot of folks tease, for example, and they say that Catholic individuals have overdeveloped superegos because they're guilty about everything. If that helps you remember, then that's a good concept. So remember, guilt and the superego very often are meshed as one. He also talked about something called primary process thinking and secondary process thinking. Secondary process thinking is more like rational thought. Primary process thinking, on the other hand, is the language of the unconscious. What Freud believed is that when you have slips of tongue are the body's way or the mind's way of getting the unconscious out. So this would be a slip of tongue. If I said, the climax in here is really hot. The climate in here is really hot. What I did was I had a slip of tongue, meaning that that was my unconscious coming out. And it came out through that slip of tongue. He also said that children, as they grow, and the id is much stronger in a child, as it gets older, the id becomes more controlled as the ego mediates between the superego and the id. It starts to mediate better. And what he said is that children say the darndest things because a child can actually tap into their primary process thinking. The id can come out and they can tell you exactly what they're thinking or feeling, and sometimes they can be very rude to people because it just literally comes out. For example, an individual or a child may see a woman in the store and the woman is really overweight, and the child will look at their mother and say, "Why is that person so fat?" Or something along that line, which is because the idea behind it is that the id is coming free. Excuse me. He also believed in free associations. And he said that if you free associate, that's one way that you can address it. For example, and a free association would be if you ask me a word, like you say tree, and I would free associate whatever words come to mind when I think of a tree. That's what you do, and you look for the themes in terms of the free associations. That's Freudian theory, but we also talk about another psychodynamic theory called ego psychology. Ego psychology is really looking at, and by the way, it's the work of many people, but very often people such as Anna Freud, who's the daughter of Sigmund Freud, and Erik Erikson, Erich Fromm, and some of those individuals are very often credited with this model. Here's the big difference. In the psychodynamic approach, in psychoanalytic, you have a psychosexual function. So we have psychosexual functioning in a psychoanalytic. In ego psychology, even though it's a psychodynamic approach, instead of being psychosexual, it's actually psychosocial. So more of an issue is placed on the social development rather than the sexual development. And many times, instead of looking at the pathological sexual issues, you're looking at healthy functioning, healthy social functioning in terms of individuals. So it's looking at more like a healthier development from a social perspective as opposed to a sexual perspective. The other thing that they believe is they believe in something called scientific determinism. And it's an important word because a lot of people hear the term scientific determinism and they think that it must be behavior mod because it has the word scientific. That's not true. In scientific determinism, what it means is that an individual is scientifically determined by their past. What it means is that past behavior influences future behavior. And many of the psychodynamic approaches believe that you have to address that past behavior in order to get to present behavior. Where most of the functional models or the problem-solving models don't really believe that you have to go back and touch that past behavior. What you would do is work completely in the here and now. In the psychodynamic approaches, you work in the here and now, but sometimes the past brings you to the present. They also believe, even though there are different areas and different models and different applications, I wanted to give you a case example and actually show you the steps for applying more of an ego psych or a psychodynamic approach. And the first thing that you do, let me give you the steps and then I'll give you the case example. The first thing that you do is something called suggestion, where the therapist or the social worker plants a seed. The next thing that you do is something called abreaction. Abreaction. And abreaction is where you begin to release feelings in a protected environment. That's abreaction, where the emotions are released in a protective environment. And you actually create something called catharsis. Catharsis. Catharsis is that release. What you want to remember is many women show catharsis or show the release through tears. How do most males cathart? Through anger. So that's that release of tension. In terms of the next stage, it's manipulation, where the social worker or the therapist directly influences what somebody is going to do and influences that plan of action. And then you end with clarification and interpretation, where you actually pinpoint significant themes. I'll never forget, this is, I think, a good case example of, as a social worker, there are many theories that we work with. And the more that we practice and the more that we're familiar with, the more that we can pick and choose the ones that seem to work the best. I'll never forget, one time I was seeing a young man and his father. And the boy was about 12 years old and his father came in. And basically the reason that they came in is that the judge had told them that if they came in for counseling, they would not press charges on the little boy. That was the deal. If he came in, dealt with his issues, they would not press charges. So the father brought him in for therapy, and I was interviewing the two of them. And I remember I said to the young man, I said, "Tell me, what's going on with you?" And the young man said, "Well, I'm making obscene phone calls." And I looked at the father and he said, "Yes, that's what he's doing. He's making obscene phone calls." And I said, "Okay." I said, "What kinds of things are you saying?" Because I wanted to know, I wanted to clearly identify what the problem was that I was working with. And he said, "Well," and he started to tell me what he was saying. And it was the way that he said it. It was almost like he was talking about having broccoli for dinner. I mean, it was just so matter of fact, the way that he was saying it. And I consider myself a street social worker. So I've been around the block a few times, and I very rarely turn red. I mean, there are very few things that people can say to me that would turn my face red. But I have to tell you, this young boy started to turn my face red. I mean, I could not believe what he was saying to these women on the phone. He just didn't look like he was capable of doing it, and the way that he was saying it was so incongruent, his mood and what he was saying, and it was just, I mean, it was, and I looked at the father, and the father said, "Yep, that's what he's saying." And I said, "Oh my," I said, "Well, tell me something. How you getting caught?" And I was expecting, him to say caller ID or, somebody overheard or anything, And he says, "I leave my name." And I said, "Excuse me? How are you getting caught?" And he repeated himself clearly, "I leave my name." I looked at the father. He said, "Yes, he leaves his name." Now think about that. If somebody leaves their name and they're making an obscene phone call, what does that say to you? Sounds like a cry for help. He wants to get caught. Now, from a cognitive behavioral perspective, I could go in and rework his thoughts. I could go in and set up a treatment plan. I could go in and get him to stop making obscene phone calls. But really, isn't there something happening here? If this young man is crying for help, isn't it important to go back and look at the past and see what is causing this? So I started to gather some history, and I said, "Okay, well, look, tell me something. The judge sent you in here, and usually they don't do that. What are your grades like in school?" "I'm failing everything." I said, "Okay." I said, "What about fights? Do you ever get in fights?" Or, "Oh, yep, I'm in trouble every single day. I'm getting sent home from school." I said, "Okay." And I said, so basically what he was telling me is he's always in fights, he's always getting in trouble, he's always getting sent home from school, he's failing all of his subjects. Looked at the father, "Yep, failing everything, getting in trouble." And I thought, well, that's unusual, because usually if you've got that kind of history, a judge isn't going to send him in. So I said, "Tell me something. How were your grades last year?" "Straight A's." "Were you in trouble last year?" "Never." So now I know that this young man last year wasn't in trouble. So it's something that's happened. I said, "How about 6 months ago?" "Straight A's 6 months ago." So when did this start to occur? 3 months ago. 3 months ago, he started getting in fights. 3 months ago, he started getting bad grades. 3 months ago, he started getting in trouble. And 3 months ago, he started making the obscene phone calls. So what does that say to you? Something happened 3 months ago. So I said to him, I said, "Okay, well, look, has anything happened in the last few months?" "No." Asked the father. "No, nothing's happened." I said, "Nothing? Have your parents divorced? Have you, anything in school? Have you lost anyone?" And he said, "Well, my mother died." And I was like, oh. And the father said, "Look, we don't have to talk about that, okay? His mother died. We were on hospice. We knew that she was going to die. It's not an issue." And I said, wait a minute. Let's start from the beginning, all right? And by the way, the father said, "And we took 2 days off to grieve, and I don't have to discuss it anymore." And he's getting really, really angry, really angry. And I said, "Okay, stop. I said, "Let me talk to your son." So I asked the boy, and by the way, now the boy is crying. So he's catharting through tears. All right, he's crying. He's crying. The father's so angry now. The father's crying. I feel like crying 10 minutes to the end of the session. And by the way, the rule with catharsis is very simple. You open them up, you better close them. And so here we were, and I'm trying to figure out what I'm going to do. And I said to him, I said, "Okay, wait a minute. Tell me something. What's your greatest fear? What are you the most afraid of? What's the worst thing that could possibly happen to you? What's your greatest fear?" Now, in terms of human growth and development, if you have a 12-year-old boy whose mother has just died, what's probably going to be his greatest fear? That his father will die, right? And actually, this young man was so bright, he said that. He said, I'm so afraid that my father will die. And the father said, that's the stupidest thing I've ever heard of. I've never heard of that. That's like crazy. He keeps saying that. I'm not going to die. I'm just fine. Everything's like, trying to get the father to stop because he was continually catharting, and actually he was scaring the boy. So I said to the young man, I said, okay, tell me something. I know that you're afraid that your father will die. What will make you, or what will help you to feel better about that? And what will stop you from making those phone calls? What will it take? Is there anything that you would contract with me about that would stop you? And he said, well, my dad and I used to go to a fast food restaurant, every Saturday while my mom was getting her treatments. We always went, and we haven't gone since, my mom died. And the father said, well, we don't have time. And I was like, wait. And I said, okay, listen, will you promise me this? If your father takes you, will you stop making obscene phone calls? And the young man said, yes, I will. I'll stop. And I said, okay, Dad, if he goes, if he stops making the phone calls, will you promise to take him? Oh, yeah, I'll stop. So anyway, we worked it out, and that's how we contracted it through. And after the suggestion, what I said is, sometimes some individuals take more than a weekend to grieve, so to speak. They have to work that through, and that takes time as a family to reunite. And then I created the abreaction where I allowed the young boy to express his emotion. Then I manipulated the situation in terms of applying that contract and getting him to agree to stop making the phone calls. And then I clarified and interpreted. And by the way, if I could have done this in the ideal world, I probably would have sent the boy, after he had that one session with me, to individual therapy to really be able to work through some of the issues. And I also would have sent that father to individual therapy. And by the way, I did send him to individual therapy. The reason I did not send them to therapy together is because I felt that the father was so angry that he had to work through some of his own issues before he was ready to deal with the death of his wife with his son. And I was afraid that the anger that he was showing was part of a normal reaction to the loss, but was scaring the young boy. And I felt that it was better at this point to separate them and then later on to bring them back. If somebody is truly in an active crisis state, you do not want to put them in a group. They literally go or belong in more of an individual therapy or into a family therapy, but not into a group, because that's when you have to address the issues within yourself. And that's considered one of the basics of when someone's in a crisis or crisis intervention in terms of direct practice. The other thing in terms of the different models, and again, I could cover this anywhere, but I'd like you to be familiar with the defense mechanisms and what the primary defense mechanisms are that are used for individuals that very often show up on the test. One of the most common defense mechanisms that you're likely to see on the test, and I give you the definitions in the book as defined by the DSM-4. So I give you the definitions that are in the book. I ask that you either use the definitions in your book, the ones from the DSM. There's a defense mechanism functioning scale in the back of the DSM that has the definitions, or the social work dictionary, because they seem to be the clearest in terms of the actual defense mechanism definitions. But some of the ones that you're most likely to see on the test is humor. Very often an individual who is feeling stress, and by the way, a defense mechanism is used to control anxiety. They may use humor. So they'll use humor to cover up the anxiety that they're feeling. They'll make jokes because it relieves the anxiety. That's a higher level defense mechanism. One of the more serious defense mechanism, but still it's one of the higher, it's called the inhibition level, it's the second level, would be something like displacement, or something like intellectualization. In intellectualization, you literally intellectualize something so that you focus on dealing with the emotional conflict through a professional way rather than dealing with your true feelings. Some others that show up, I list them all out for you. I advise you to look through them. But some of the most common: acting out. Acting out is actually a major image distorting level of a defense mechanism. And acting out we very often see in adolescence. Acting out. Acting out is where you act out through action rather than saying what you really feel. So a good example of acting out is the child who is really angry with their parents and runs away from home or stays out all night. That would be acting out. What you want to remember too, in divorce cases, the child will usually act out most on the parent that stays, because they've got all this anxiety and that's the safest parent to do it with. So the parent who stays very often sees a child who now begins acting out or acting through action rather than telling them how they really feel. Another one is denial. Denial is a common one where you refuse to accept. You literally just put up a shroud of denial and refuse to accept that there could be a problem. Another one would be suppression and repression. Suppression is a higher level defense mechanism where you just literally avoid thinking about it. That's suppression. If you're looking at repression, repression is unconscious. That's where you literally bury that inside and you don't know it's there. Another example of a defense mechanism would be reaction formation. This is where a feeling or a thought is inserted, and often reaction formation accompanies repression. So if we take the individual who has obsessive compulsive disorder and they're very anxious about leaving the house, well, what happens is they begin to really lose sight of their anxiousness about leaving the house, and what they do is the reaction formation is they check the door 100 times to see if it's locked. Or they have these rituals that they must go through in order to be able to deal with the anxiety, but they're not in touch. They don't know that's why they're doing it. It's unconscious. Another one that is common is projection and projective identification. And I want to make sure that you know the difference between projection and projective identification. Projection is a more mild defense mechanism than projective identification. But in projection, what you have is you can't deal with your own feelings, so you falsely apply those feelings to someone else. If I feel this way, then you must feel this way. That would be more of a projection. Projective identification, on the other hand, is where you join with the other individual and actually identify with them, which we very often see in dependent personality disorder, where it becomes one. You mirror the other person, and it becomes very difficult in practice how to see this and how to negotiate this. I'd like to give you an example of projection leading to projective identification. And then I'd like to give you an example, a clinical example of projective identification where you don't see projection that led to projective identification. Now let's start. In terms of projection, I'd like you to imagine that you are, I'm going to use a song, and it's by Roberta Flack, but it works really well to show you how projection leads to projective identification. I'd like you to close your eyes for a minute and relax. And I'd like you to imagine that you're sitting there, and there's a young woman, and she walks into this bar. And by the way, the young woman is what we call Yavis. Yavis is a term that we used to use. It means young, attractive, verbal, intelligent, and successful. So she's this young woman who comes in, and she walks into this bar, and there's a young man who's singing a song, and he starts to sing about her. And so it goes something like this. This is a good example of projection. It goes just like this. I heard he sang a good song. I heard he had a style. And so I went to see him to listen for a while. And there he was, this young boy, a stranger to my eyes, strumming my fate with his fingers, singing my life with his words, killing me softly with his song, killing me softly with his song, telling my whole life with his words, killing me softly with his song. I felt as if he knew me in all my dark despair, and then he looked right through me as if I wasn't there. Okay, what do we have here? We have a young girl. She walks into a bar, and she's a Yavis, right? Here's this guy singing about her. So she goes up to him and she says, you know, I have to tell you, I felt that you were singing about me. I felt that you knew everything about me. I felt that you just opened me up to the entire audience. I felt that you and I just had this connection. And he says, kind of cute. She's a Yavis. Yeah, I felt that connection too. Yes, I've got it. Yes, you and me, I've got it. So it all starts with coffee. They go out and have coffee together. Then one thing leads to another. They start dating regularly. Then they get married. They have sex. Now they're in your office because things aren't going so well. Now this is projective identification. In your office, when you start to work with that couple, the mirroring becomes so complete. The personalities are so complete or so molded together that you can't tell if she really feels the way she does, or if she feels that way because he made her feel that way, or she's feeling that way because she wants to feel that way because he wants her to feel that way. You don't know who did what to who. They become one. And you can see how difficult that can be in therapy. So projection then would be where you cannot deal with your own thoughts and feelings, so you falsely apply them to someone else. She projected what she felt onto him. Projective identification is when the bonding or the mirroring becomes so complete that the individuals become one. Let me give you another example now. Let's do projective identification by itself. This is what is so difficult with people in the therapeutic session or when you're working with clients, because when they present with projective identification, it's very hard to figure out who belongs to who. I'll never forget the most perfect example I can give you of this is I was working with a client, and the client came in, and this woman literally was absolutely beautiful. She came in and she was dressed immaculately. She was the kind of woman that had the shoes that matched the belt, that matched the scarf, that matched the colors in her hair, that matched she looked like she was just walking out of Vogue magazine. She was gorgeous. She got out of a beautiful car. She came in. She was a very well-to-do. She was a bank president. She had all of this wonderful stuff going for her in terms of her career. Very successful. Anyway, she came in and she said, "Doctor, I just want you to know that I'm getting a divorce, and I'm absolutely devastated by it, and I don't want to do that, so I'm here for divorce counseling." And I said, "Okay." I said, "Well, tell me a little bit." And she started to talk. And the more she started to talk to me, the more confused I started to get as to how much she really felt or how much she didn't. So I asked her to consider doing a technique for me. And I do it, it's like a modified family circle. And what it is I ask the client to draw a circle. And I role model for them what to do. And then I ask them how their life is. And then I ask them to draw the circle and ask them how they want their life to be. And usually I do just a very brief role model for them so that they can get an idea of how to do it. And usually what I do is I'll do something like this. I'll say, this is my husband and this is me. I drew us both about the same because I see us as both pretty equal. We have a daughter and we have a son. And that's pretty much my family. That's the way my family is, and this is the way I want it to be. And I usually draw the same thing because I'm pretty happy with my life. Now will you draw your life for me? So that's what I did. And then what she did was she drew this. And I'm not very good at drawing. She was much better than I was, but this is a tree. And on the tree, she put a piece of fruit. And now you remember, I did squares and circles, and I was thinking genograms, and she drew a tree. So I said, okay, tell me something, all right? That's the tree. Tell me what that is. And she said, it's a tree. And I said, okay. And I said, tell me about it. And she said, my husband is the tree of life, and I am the fruit that he bore. And I said, oh, okay. And this is divorce counseling. I said, all right, well, tell me, how would you like your life to be? Tell me the way you want it to be so that I could help to set some goals in terms of what it was that she wanted. You know, what did she want to come out of the few sessions that we had together? And she drew a tree. Same piece of fruit. And I said, okay, explain that to me. I'm thinking maybe he's the tree of life. I mean, I don't know. She says, no, my husband is the tree of life, and I'm the fruit that he bore. And the more that we talked, the more that I realized that the shoes that matched the belt, that matched the shirt, that matched her hair, he picked them out. He used to do a monthly schedule that actually put together exactly what she was going to wear every single day. And one of her greatest fears was that she only had about a week's worth of clothes, you know, if he left her, that she could put together, and that people were expecting to see her dressed in this certain way, and she didn't know how to do it unless he was there to help her. She also talked about how he used to do schedules for preparing the meals and telling her what to cook and what to say. And I mean, she was devastated because she was so identified into this man. Now, usually when I do divorce counseling, what I do is I build the individual without the partner. I mean, that's what we want to do. In this case, I wasn't sure what to do because I wasn't sure where to start. So here's what I did. I said, tell me something. Will you ask your husband to come in and we'll do a session together? And she said, oh, he'll never come. I said, he'll come. Tell him it's for you and see if he'll come. And immediately he agreed to come. Then what I said to her is, what I'd like you to do when he comes, because I want to try something. I want to see how he is going to respond to your becoming independent. What I'd like you to do is I'm going to do this is-be stuff. We're going to draw the circles, and I want you to draw the way you know, your life is. Only this time, what I want you to do is draw him as big and you as little, the way that your life is, and then draw him as the same size as you outside of the circle and you by yourself, because you're going to go on by yourself in terms of a divorce. She said, okay, that's what I'll do. So he came in, and what we did is I had him draw how he wants his life to be first, how it is and how he wants it. And what he did is he drew himself real big in the middle, and then he put two women in the circle. And he said that basically he had his wife and his girlfriend who he wanted to, you know, marry. They were in his life right now, and he wanted to continue, and he wanted his wife outside of the circle, you know, and he wanted to bring his girlfriend in. So then I had his wife who was my client, draw the way she wanted her life to be. And so she drew it exactly the way I told her. She drew the two together, and then she drew her by herself. The minute she did that, he looked at me and he said, you know, I think I want to draw mine again. I think I might have missed it. I want to go back. I've been thinking about it, and I want to go back. I want to draw it again. And I said, you want to draw your circle again? He said, yeah, I want to draw it again. So he redrew it. And you know what he did this time? This time when he drew it again, he drew himself and actually pulled her back into the circle. Because just as much as she was mirroring him, he was mirroring her. That's projective identification. It scared him half to death when he saw that she wouldn't be there. He didn't know if she became independent enough to work it out without him. He was scared to death about that would happen. Now, you do need to know the defense mechanisms. Another theory that you can look at, and let's go over a sample question. L has a child who was recently diagnosed with a terminal illness. L tells the social worker that her child is not ill and will not be returning to the clinic for follow-up. Which of the following defense mechanisms is best represented by L's response? So which defense mechanism is best represented? So we've got a person whose child's been diagnosed with a terminal illness. Which defense mechanism? A, rationalization, B, denial, C, intellectualization, or D, projective identification. In this case, the person tells the social worker that her child's not ill. She's in denial. So the answer would be B, denial. The next model that I'd like to talk about is Gestalt therapy. In Gestalt therapy, the actual founder is very often referred to as Fritz Perls. Gestalt therapy is very much focused on the individual in the here and now with immediate awareness of personal experiences. And very often in Gestalt therapy, what you do is address unfinished business. You want to go in and address your business. You want to finish your business. And a good example of Gestalt would be the empty chair. The empty chair is something that we use regularly, for example, in bereavement. The empty chair would be if I had that father who had lost his wife with the little boy, if I had that father in Gestalt therapy, what I might do is have the father sit in a chair and then take an empty chair. And I would say to him, if your wife was sitting in this chair now, what would she say to you? What would you say to her? So what you allow is people to focus in the immediate awareness, in the here and now, but it resolves unresolved feelings of guilt, where they can actually get to say goodbye to their loved one when their loved one has passed away. So it's a technique of bringing things into the here and now. Thank you. Hello. We're going to continue now with the practice in terms of direct and indirect practice. And I want you to remember that in this section, this is a very large section that covers every exam from the basic into the clinical exam. In terms of direct practice, some of the exams weight this section as much as 23% to as little as 19%. In communication, it can be as much as 7% to as little or to as much as 9%. And in relationship issues, as much as 4% to 8%. This section actually includes all three of those. And again, there's a tremendous amount of overlap between the sessions. Like you'll see in the assessment section, we did some research. You'll also see in this section, we'll do some assessment and some of the other areas as well. In terms of where we left off, we just talked about Gestalt therapy. And what we said is that the focus was in the here, now, immediate awareness, and very often you use techniques such as psychodrama or the empty chair. The next one that I'd like to talk about is something called object relations theory. Object relations theory is actually a human growth and development theory, and probably the majority of the work that was done in object relations is introduced, or basically is the work of somebody named Margaret Mailer. What she talked about was how a child must separate and individuate from the parent. So what you do is separate, and then later an inner representation of the mother develops when the child completely individuates from the mother. Let me give you an example of separation. Many children that do or that utilize or in practice of this model will use an object to separate from the mother. If you ever think of the Peanuts cartoons and you think of Linus, where Linus is constantly holding the blanket, that's a very good example of object relations and separation, because what they would say is, in terms of reaching separation, the blanket now begins to represent the mother. And based on that, the child is able to separate from the mother using the blanket. Eventually, the child no longer needs the blanket and can put the blanket away. When that happens, then the child has individuated and the inner representation of the mother occurs. Now, there is also a stage right before individuation that people have talked about or has shown up on the test. It's called rapprochement. Rapprochement is the stage where a child has not fully reached individuation, but is pretty close. They're just about ready to reach individuation. A good example of rapprochement. I'll never forget one particular time I was with a friend of mine, and she had a little girl, and her daughter was with us in the back of the car. And we were driving outside of Atlanta, and we had gotten, and look at the age. If you see a test question, to understand this concept, always look at the age. The little girl was about 7. Anyway, we were driving in the car, and we got about an hour outside of Atlanta, and we were heading home. And as we got out there, I remember the little girl said to her mother, and this conversation ensued. She said, "Mom, where's Fluffy?" Fluffy Muffy was her rabbit that she used to carry. She said, "Mom, where's Fluffy?" And her mother said, "Well, honey, it's in the trunk." And she said, "Well, Mom, did you put it in the trunk?" And her mom said, "No, I didn't put it in the trunk. Did you put it in the trunk?" Anyway, this discussion started to go back and forth, and the little girl became more and more anxious and more upset about Fluffy. Now, we had just spent the weekend together in the same hotel room, and I have to tell you, I never saw Fluffy. I didn't even know Fluffy was there, but obviously Fluffy was there. So eventually they started to get so upset that I pulled the car to the side of the road. And when I did, we went into the back and checked the trunk. Well, guess what? No Fluffy. So the little girl was really upset. So what her mother did was, we had a cell phone, she called the hotel. She called the hotel and eventually got the maid on the phone. And the maid got on the phone and said, yes, indeed, she had found Fluffy, and she was going to mail it back. Well, that wasn't going to work. The little girl had to have Fluffy. She had to know that Fluffy was going to be there, and she was continually crying, and the mother was upset. Anyway, what we decided to do was drive back an hour to Atlanta to go get Fluffy. Now, as an adult, I was willing to do this because I saw how anxious and upset the little girl was. We drove all the way back. We went in and got Fluffy. Now, I'm expecting all the way back that the little girl is going to be holding on to Fluffy and just, loving this thing because, and we literally drove 2 hours out of our way to go back and get Fluffy. And so I'm waiting for her to be hugging this thing and all of that stuff. Anyway, we get back to the car, and what does she do? She throws Fluffy in the trunk. And I said, wait a minute, you just threw Fluffy in the trunk. She says, yeah. She didn't want Fluffy with her. She just wanted to know where Fluffy was. That's rapprochement, where you get to the stage where you're almost ready to individuate, where the inner representation of the mother is not quite there yet, but it's close. And eventually what the little girl will do is put it up. She will actually put up Fluffy, and then she'll no longer need it. That's when individuation has occurred. Now that's a good example from someone who uses an object. But what this theory says, object relations, is that the same thing could happen to a child that doesn't use an object. So you have the same kind of thing happen, but they don't use an object. And let me give you an example of another story about a child who is also in the stage of rapprochement, but does not use an object. Now this child is about the same age, between 7 and 8. And the little girl says to her mother, Mom, I want to take a shower. And by the way, this little girl has never been an object child. Like she's never had a teddy bear. I mean, every now and then she'll sleep with a different toy or whatever, but she's never had a blanket. She's never had an object. Anyway, she says, Mom, I'm going to take a shower. And her mother says, okay. And she says, and listen, while I take the shower, I don't want you in the bathroom. And the mother says, all right. She says, but I just want to make sure. Mom, I don't want you in the bathroom. So the mother says, well, I want to make sure. Do you have soap? I have the soap. Do you have towel? I have a towel. Do you have shampoo? I have shampoo. Mom, I mean it. I don't want you in the bathroom. I want you out of here. I don't want you there. So the little girl gets in the shower, and the mother hears the water running. And when she hears the water running, the little girl is being independent in the shower. She ends up stepping outside to look at something. While she's outside, she hears hysterical screaming in the house. She goes running in, and the little girl has come out of the shower, and she's naked, running across the floor, hysterically screaming. Well, the mother looks at her. She's not bleeding. She's not hurt. And the mother can't figure out what's going on because this little girl is hysterically screaming. And she's trying to calm the little girl down, and the little girl won't calm down. She's crying and crying and crying. And so finally the mother grabs a towel, wraps it around the little girl, and she says, calm down, calm down, calm down. And finally the little girl calms down. And the mother says, what's wrong? Tell me what's wrong. And the little girl says, you left, you left. She starts screaming, you left, you left. And the mother says, well, you told me that I could leave. And she says, no, you left, you left. And every time after that, for probably about a year or so, every time the little girl takes a shower, one of the first things she says to her mother is, you leaving this time? You going somewhere this time? What that is a good example of is rapprochement. In that case, the little girl was so connected to the mother that when the mother was gone or the mother didn't answer her call while she was in the shower, she panicked and she came running out. So even though she's trying to build her independence and develop her own identity, she would still be linked to the mother. That's a perfect example, I think, of rapprochement. But it's rapprochement without an object. So if a child uses Fluffy, all right, to separate from the mother and eventually individuate, or no object, as in the shower example, those would be cases of rapprochement. In object relations, what you're looking at, again, is you're looking at separating from the mother, and then eventually using or developing your own inner representation of the mother so that you individuate and you no longer need to be connected to the mother. And by the way, in this model, they say that it's usually the mother. And there's been some question as to whether or not fathers may take over that role if they were the primary caretakers in terms of what would be considered non-traditional relationships. It does not appear, though, so far to be that case. It still seems to have that connection to the mother. In terms of client-centered theory, a new model. Client-centered theory is the work of Carl Rogers. Carl Rogers is the one who did a lot of what they call ex post facto work. What he did was ex post facto, means that he was one of the people that did post fact. So he actually went out and did the therapy and then wrote about it. He didn't write about it and then prove it worked. He did it and then he wrote about what he saw. He also believed, very similar to Maslow, in terms of self-actualization and the development of an individual to self-actualize, or their own building of self-esteem or self-image. He is the one who used a tremendous amount of what we call reflection or active listening. This would be a good example of Carl Rogers, and I'm sure you've heard this example probably when you were in class. But they'll say, a client will say, I'm having a bad day. And Carl Rogers will say, it sounds like you're having a bad day. And the client says, yes, I'm having a terrible day. Now, Carl Rogers did something called active listening. Now, here's where the key is. Instead of just repeating back what the client says, he often does something called paraphrasing as part of the reflection. So if the client says, I'm having a bad day, Carl Rogers might say, sounds like the events of your day are really causing you trouble. So he's actually taken that client a little bit further. The client says, yes, my son is making me crazy. And then Carl Rogers would say, it sounds like things that your son is doing is really bothering you. And so he's actually, in paraphrasing, you don't only give back what somebody is saying, you clarify what they're saying, and you can actually take them to a little bit of a higher level. That's reflection, or active listening, as Carl Rogers would have explained it. Another model or another theory is something called systems theory. And what I always say is systems theory is much more, to me, I always think of it as an umbrella. And systems theory is more to me like a framework for that umbrella. And all of the other models come under the umbrella or take parts of systems theory so they don't get wet, basically. Good examples of models that incorporate the systems components would be family therapy, many of the branches of family therapy, ecosystems therapy, any of the theories that take into account a systems component or add a systems component. Now remember, one of the major differences between models that use a systems framework is this whole idea of circular reasoning. Instead of having that old linear model that goes from problem to solution, now what you have is the circular, where we have a problem, solution, and it's fed through feedback loops. That's your linear model. Excuse me, that's your circular model, the opposite of the linear model. You also, in systems, we believe that society has the obligation to ensure that people have access to resources. And probably one of the most significant factors in systems theory is that problems are viewed within the system, not necessarily within the individual. Recently, I was in court testifying in forensic social work on a case. And one of the issues, this is a perfect example of systems theory. One of the issues that we struggled with was this individual had been in numerous problems. Now, it doesn't make the crime that was committed okay, but it helps you to understand the background of what the person had been through. The person had been abused by his parents. The person had worked as a migrant farm worker, literally had been away from home, ran away from home at the age of 12, ended up with an older woman, had children with that older woman at the age of 15. So what you had is somebody who had literally been in a system or raised within a system where the drug culture was very common, where he had used crack cocaine before he was even 15 years old, where he had been stabbed to death, where he had been in a coma, where those were things that were products of the environment that contributed to a lot of the way he perceived things and a lot of the development that he had. Now that doesn't give somebody an excuse for committing a crime, but from systems theory, it helps you to understand why someone would do what they did. And it has to do with the environmental influences that have basically fostered the value base or the belief system that an individual has. In systems theory, we often talk about the change agent system, the client system, the target system, and the action system. But what I would like you to remember more so for the test is what we call the techniques that are used in systems, because many of those models that come under that umbrella use those techniques. And the way that I remember them, if it works for you, good. I always think of Laverne and Shirley, you know, as they're going down the street and they're singing hand in hand, Shamil, Shmal, whatever that is they sing. Well, what I'd like you to remember in terms of social work, I'd like you to say these to yourself and then out loud, because it'll help you remember them. I say one of the premises, or the primary premises, are educate, advocate, facilitate, and intervene. Educate, advocate, facilitate, and intervene. Now, what I'd like you to do is say those words with me, because if you say them with me, they're more likely to click in your memory. Educate, advocate, facilitate, and intervene. Woo! Educate, advocate, facilitate, and intervene. In social work, what we do before you do anything else, almost always, is we educate. And we educate our clients so that they can make informed decisions. I'll never forget when I worked with an individual who was a diabetic, constantly would not follow his diabetic diet. He was beginning to have eye problems. He was having all kinds of effects because he just did not. They had the dietitian meet with him. They had him go over it. You know, he had been educated and educated and educated on the issue, and he still was non-compliant. When I went in and met with him, I realized something very quickly. Who cooked the meals? Him or his spouse? His spouse. And what was happening was all the education that the medical team was focusing on was on him, not on her. That was doing the cooking. So one of the first things I did was brought her into the session and allowed her and actually worked with her in terms of educating her in regards to the types of foods that he needed. And she became part of the plan or part of the treatment, and he followed his diet after that, because now she was able to. So education then is more than just educating the client. It's looking at the system and making sure the system is educated in terms of what an individual needs. That's the system. Also, in terms of education, if a client has HIV or AIDS, before you would go and tell someone that that individual has HIV and AIDS, it's best to educate them to make sure they know what HIV and AIDS is. Very important points in terms of education. So we educate, we advocate. And what you need to remember that's so important in social work is the whole concept of advocacy. And advocacy means empowerment, client empowerment. We want to advocate for our clients as much as we can. I'll never forget there was a time when I was doing a conference and I was speaking to a group of social workers. And it was interesting because many of the social workers do case management functions and many of the nurses do case management functions. And there's always been a little bit of a rift in healthcare between nurse case managers and social work case managers. And one of the rifts that has always been there has been the fact that, number one, nurses get paid more and usually have less education. But number two, that very often the nurses were very focused on discharge, referral, and getting individuals out, where the social workers seemed to take more time working on issues and working with clients. And it was interesting because when I used to work in nursing, I used to be a nurse way back when I did that, I know that idea of how to handle certain things and how that was taught and how different that is from social work. Now, what you've got in nursing, and I'll never forget, I asked the case managers who were nurses. I said, tell me something. What is advocacy? What is advocacy to you? What does it mean in terms of case management? And they said, well, advocacy means helping clients. And we help clients through referrals. We work with clients. We, basically get them the services that they need. That's what advocacy is. And it is. That is what advocacy is. But I went to the social workers then who were case managers, and I asked them what advocacy is. And they told me that sometimes they end up taking what might be considered too much time with clients. And the reason that they take too much time with clients is because of the way that they perceived advocacy. The way they perceived it was providing referrals and giving clients the services and the connections that they need. But in addition, it was teaching them how to use the services. So do you remember the old adage, give them a fish and you feed them for a day? Teach them how to fish and you feed them for a lifetime. The social workers, as they addressed education, were teaching clients how to fish. They were teaching them about the services. And it's interesting, particularly in emergency rooms and in many of the case management teams, social workers were being replaced initially. What we found is that recidivism rates, meaning that people were indeed being discharged, but they were being readmitted. And so what we have now started to see in healthcare is that social workers are being put back on the teams. Now, the bad news is that they tend to be given some of the most difficult cases because a relationship has been made in terms of teaching them about the services and making sure they're ready for those services and recidivism rates. So social workers may not be getting as many referrals, which is very often how we count our beans, but they are teaching them how to use the services. And that is a vital component of any case management team, and that is being recognized. So when you look at education, we want to educate and empower folks, absolutely. So we want to educate, advocate, and advocacy in social work means empowering the client to use their own resources to get them to do for themselves. Educate, advocate, facilitate. Before you go and you tell a client or report something, if there's any way at all that you can facilitate the client's empowerment to do it for himself, the better. Say, for example, a client feels that they are being discriminated against by an agency. You could actually step in and do what needs to be done for that client. But it's a lot better to facilitate the process and have that client empower themselves. So what's better to do is to tell the client what their rights are or to get them connected to someone who can help them tell them what their rights are. So we would facilitate before we intervene. And the last step is called intervention. In intervention, we actually step in and intervene or do for the client. For example, in crisis intervention, if a client is in a crisis situation, I'm much more likely to intervene, meaning that I wouldn't tell them to go to a group, I'd take them. I wouldn't tell them this is a good thing to do. I'd help them create a list so that they can actually act out what needs to be done or act on what needs to be done from that list. So in systems theory, the whole idea of educate, advocate, facilitate, and intervene. And remember, in terms of communication issues, in terms of relationship issues, in systems theory, many of the other models use the premises of systems. So they actually look at these principles even though it might be another model of practice. The next model that I'd like to mention is ecological systems perspective, or ecological systems theory. This has become very popular in terms of adaptation and goodness of fit with the environment. Many times clients will focus on primary prevention strategies and work with individuals from this perspective. Also, you may have heard of something in social work. There is something called the PIE, the P-I-E, the PIE. And this is not to be confused with a record-keeping system. The PIE, the P-I-E, it's called the person in environment. The person in environment is basically social work's answer, what I believe, to the DSM. When it was first formulated, a lot of social workers felt that the DSM was too medical model oriented, and it started with a diagnosis or a mental illness, and then it branched off into Axis 4, which is the stressor, and 5, which is the global assessment of functioning. The PIE is almost in a backwards sense. What the PIE does is it starts out with stress factors. It starts out with dealing with an individual's stressors, or what's happening in an individual, the environmental conditions. And then later it mentions what would be on axis 1 and 2 of the DSM and axis 3 of the DSM. So what the PIE does is factor 1, factor 2, factor 3, etc. And it looks at the way an individual, it starts out with the environmental focus as opposed to a mental health focus. The next model is family therapy. And what you want to remember in family therapy is there are many different approaches and many different theorists. Probably the most key issue in family therapy is that you remember that the focus is on the family. The focus is so prominent on the family that some individuals won't even see you that are family therapists unless the whole family can come in. They won't see you. Others will say, yeah, I got to make a living, I'll see you. But what you do is you treat the individual as a family. And if you look in the DSM-4 and you look in the very beginning of the book, it says who the DSM is designed for. It says it's designed for mental health professionals, for social workers, for psychiatrists, for psychologists, for nurses, but it does not say it's designed for marriage and family therapists. And the reason for that is the DSM provides an individual diagnostic classification, where in family therapy, the focus is on the family. They would not break the family up. They would see the family as one in terms of communication patterns. They also believe in family therapy that one of the models that has been resistant or basically has found some fault in family therapy is feminism. And it's easier to kind of give you an example of why feminists are sometimes don't like the way gender is treated in family therapy. For example, let's use age. If I have a 5-year-old and a 30-year-old, don't think gender, think age. 5-year-old and 30-year-old. Are these two individuals different? Yes. Would you expect different things from a 5-year-old and a 30-year-old? Yes. You would expect different things from them. The beef in family therapy would be that if you act like a 5 and a 30-year-old are equal, and they're not, you start out with an unequal power balance that sets the whole relationship off key. Now let's take gender. What they believe is there's a difference between men and women. And no matter how hard you try to work that difference out, it's still going to be women in one position and males in another. And they feel that this power imbalance, and it's more than salary, it's a societal view. If you act like men and women are equal and then you address the differences, you're missing, just like in age, you're missing the differences. So what the feminists prefer is that family therapists actually acknowledge that there's a power imbalance. And it's always going to be there, and it's not going to change. And that you address that before they get into the therapeutic session, as opposed to after. In family therapy, what you'll remember, I remember when I used to teach physicians at the medical school, one of the things that we did was we audio taped and videotaped everything. There was a video camera in every single room, and we were constantly videotaping our physicians when we were teaching them family therapy. The reason for that is the videotaping serves to make the practitioner an objective observer. What you want to do is videotape your interaction and then watch it so that you can sit back and critique. And I promise you, if you took a family therapy course, you had videos and audios. I promise you. Because they really like the idea of videotaping. Because you can become what they call an objective observer. To actually go back in and look at how you could have done things differently or how things could change. There's also a technique called prescribing the symptom. Prescribing the symptom is actually a paradoxical approach to addressing something in prescribing the symptom. I like to call prescribing the symptom more of the same. A good example that maybe, for example, Minuchin might have used might be you have a couple that are fighting. This is prescribing the symptom. That's why I call it more of the same. You have a couple that are fighting and they're fighting all the time. They come in for a session, and what you do is you tell them to go home and fight, more of the same. They're going to fight every day between 4 and 5 o'clock. That's their fighting time. That's when they have to fight. Well, the idea behind this is eventually they'll realize that they have to fight, and fighting is silly, and eventually they'll stop the fighting. So it's called more of the same. It's prescribing what you're doing. I will caution you, however, in today's environment, I think that you need to be extremely careful about ever telling a couple to go home and fight. Because many times people have guns or weapons, and if they are, or they lose control and something happens. So I always handle negatives in a session, not outside of the session. So you would definitely want to address that fighting, but only within the session. If you're going to give them homework to do outside of the session, it's much better to give them a positive thing like what attracted you to each other. You know, talk about what attracted you to each other. This way you're looking at something positive outside of the session as opposed to negative. Always include negatives in the session. Now back to prescribing the symptom. That's the technique, more of the same. It's also, I had said earlier, that social workers really like theory. They really feel that you shouldn't just use a technique, because if you use a technique and you don't know why you're using it, you literally could get lost in that technique. So what I'd like to remind you of then is this would be a negative example of prescribing the symptom, where somebody uses the technique but they use it incorrectly because they don't understand the theory. For example, a woman catches her daughter smoking cigarettes. So what she does is she buys a pack of cigarettes and has her daughter sit at the table and smoke cigarettes in front of her until she gets sick. Or the father the young man goes out and gets drunk. So the father goes out, buys a 6-pack of beer, and sits there and watches his son drink every can of beer in front of him until he gets sick. That would be a good example of prescribing the symptom, but a bad example of the application. That's somebody who uses a technique but doesn't understand the theory. They don't understand why they're doing what they're doing. And so they can misuse a technique because they don't understand the theoretical foundation underneath that technique. We also talk about in family therapy homeostasis. Homeostasis is where you balance or reach equilibrium within a family. And the bottom line is whether you push in positive feedback a family to make changes, or you get a family in negative feedback to withdraw to make changes, each family member is going to reach a homeostatic balance. That's what they believe in family therapy. In terms of the definitions of family therapy, what I'd like you to remember, if terms look like family therapy, there are two groups of individuals that or two models that very often confuse practitioners as to what the meanings are. And I want you to be aware of this on the test. The two groups where the words don't always mean what you think they mean are family therapy and behavior modification. The words have very pronounced meanings, and sometimes you don't realize what those meanings are. For example, wholeness. In family therapy, the term wholeness means that changes in one part of a system will actually change the entire system. Negative feedback is where you take the family to a comfortable balance. Positive feedback is where you push the family into change to have a comfortable balance. Non-summativity. Non-summativity is the old adage of 1 + 1 = 2. Well, in non-summativity, the idea is that 1 + 1 can equal a very different 2, depending on who the 1 + 1 are. They're not the same. You also have entropy, where there's a natural tendency to move towards disorder and disorganization. In terms of some of the theorists, one of the oldest theorists in terms of the old foundation of family therapy might be somebody like Ackerman. And what Ackerman had a very psychoanalytic approach to family therapy. There are also what we call communications family therapists. Some examples that might fall in that area. And again, please remember that many of the family therapists, the famous family therapists, use a combination of techniques. But primarily communications would be Satir and Whitaker. And what they talked about is what we call experiential family therapy or experiential techniques. And experiential techniques, remember the word experiential, based on experience. Experiential means that you're experiencing it, you're living it. It's a type of learning that occurs through experience. That's experiential. And for example, one of the techniques that's very often used in communications or family therapy that was introduced and talked about a great deal by Virginia Satir is something called family sculpting. Now, what you want to remember is that family sculpting is an experiential technique. So it's not a paper and pencil technique like a genogram or a family circle. This is an experiential technique. Let me give you an example of an experiential technique. Let's make believe that we are in Family Therapy 101 and the video camera is playing. And I'd like you to imagine somebody, for example, Virginia Satir on screen. This is family sculpting. And she's on screen, and she has, with her, she has a father, a mother, and a child. And
The child is feeling that the mother is always yelling at him, always, berating him, always, using her power against him. So this is what Virginia does. She's on screen and she says, I was thinking. Let's try this. Mom, stand up. Stand up. John's the boy. John, stand up. Okay, John. Now, what I'd like you to do is pose yourself. What does it feel like when your mother is yelling? Show me what that looks like. And so John goes, oh, I feel like, okay, now Mom, John, pose your mother. What does your mother look like when she's yelling at you? Pose your mother. So John poses the mother, and she ends up standing like this. So now you have Mom standing like this, and John standing like this. And she says to Father, how do you think that must feel for John? Okay, now, Dad, you take Mom's place and stand there. Now, Mom, you look. How do you think that feels for John when that's family sculpting. What you're doing is you literally have them sculpt out or act out in an experiential way what is going on in the session. The other thing that's very important in terms of communications theory is this whole idea of it is impossible not to communicate. In this type of therapy, you communicate no matter what you do. They call them meta communications. So if I said to you, I'm open to what you're saying, and I cross my arms like this, you can see that even though I'm saying I'm open, my face is saying I'm not. My body is saying I'm not. So that is a meta communication. A meta communication simply means something underneath the surface that sends a message that you may either mean or not mean to communicate. In terms of extended family systems, usually that's the work of Bowen. And again, I'm sure we're all familiar with, but just to go over some of the basic rules of the genogram. The genogram. What you have is something called the genogram. And a good example of the genogram is usually we do 3 generations, and we start with somebody called the IP. IP. The IP is basically the person whose genogram you're doing. So if I was doing my own genogram, I would be the IP, the identified patient. That's the term that they use. So let's just say we're doing a genogram and say it's mine. And usually circles are females, squares are males. So if I was married, all right, to my husband who's male, we could put when we married. If we divorced, we could put 2 lines usually, divorce, and then what the date is. You also, if you have children, you usually do children. Squares, again, are usually males. Females are circles. We don't create things. We don't create our own symbols. We follow the pattern in a genogram almost always. Also, you want to do 3 generations. So very often what you do is start with the IP, and you might want to go up to the parents and the grandparents, or you might want to start with the IP, and you might want to do the children, and if they have children, if the child, marries and then they have children, or however that works, you have grandchildren, you might want to do the 3 generations down. When somebody dies, usually what you do is X them out. There's an X that's placed on top of them. But that's your genogram. Now the difference between a genogram and an echo map. Echo map. An echo map is another paper and pencil technique. And very often what you do in an echo map is you start out with whoever is in the household. If these 2 individuals are in the household, that's who you start out with. And then what you do is you map out what are the relationships with other agencies or other things outside of that situation? Like, say, for example, they're on food stamps, or say they're on the church is important, or say their job is important. And very often you might measure a tenuous relationship or a strong relationship between individuals and certain things within their environment. That's an echo map. Again, that is not an experiential technique because it's paper and pencil driven. In terms of structural family therapy, you're very much interested in behavioral change, transactional patterns. Sometimes you want to improve the process of the family, and techniques are often direct confrontation with the family. You might use prescribing the symptom. Now, it's this method of family therapy, structural family therapy, that is very good in terms of outcomes. So if you ever see a question that says, what would be better for measuring outcomes? Or what would be better in terms of measuring goals? It probably would be, structural over strategic, because structural is so patterned, in terms of how each situation is structured. The next type is strategic. Strategic is very often the work of Haley. And a good example of what Haley might do is he actually gets directly involved with the family. So he blends in with the family. A good example of strategic family therapy might be something like you use your role as a therapist to interact change. So say, for example, I have a couple in therapy and they're fighting. The male, say it's a male and a female in therapy, and the two of them are fighting. They're fighting. And I am the therapist in that session. What I might do, say I feel that the male is really bullying the female, and so she is pretty much cowing back because she's afraid. Then what I might do is say to the male in this relationship, I might say, wait a minute, all right, I'm not afraid. Let's talk to me. Let's see how you would handle this with me. And then what you do is you join in. I wouldn't want to be talked that way. And so you join in with the family. In structural family therapy, you would never join in. In structural family therapy, you structure the communications. Where in strategic, you're much more of an interaction effect. You literally join in, and strategically, you will do whatever it takes to bring about changes for that family. Behavioral family therapy is also a type of family therapy which Lieberman first introduced. And in behavioral family therapy, it uses very heavy the principles of social learning theory. In terms of specific relationship issues, this is as good a place as any to talk about them. And I want to make sure that you understand the difference between transference and countertransference, and how to handle that in a session. Now, most of us know transference and what that means, but there's also something called countertransference. Transference is what happens when you're working with a client. So you're the social worker or the therapist, you're working with a client. And this would be a good example of transference. The client perceives you as acting like someone else, like being somebody in their past, setting rules that they don't want set. And so they basically almost attack you or confront you as if you were that other person. For example, a client says to you, my sister's the same way as you are. My sister does the same kinds of things that you do. I feel like, just like my mother and father, you're pushing me into this. That would be transference. Transference is a therapeutic relationship where the client basically transfers
or pushes feelings onto the therapist that the therapist does not have. That's transference. Now, what's countertransference? Countertransference is where I'm the social worker and the client are in therapy, but the difference is I push my feelings or my perceptions onto the client. Say, for example, I've worked with the client in domestic violence, and this client reminds me of a client I just finished working with. And she says that she has the same mannerisms and maybe some of the same expressions. And so I start expecting this client to do what my other client did. I start attributing my other client's characteristics to this client. That's countertransference. So in transference, it goes from the client to the therapist. In countertransference, it goes from the therapist to the client. That's the difference. Now, here's how we handle it in therapy. Transference. If I see that a client is transferring to me, the first thing that I would do is recognize that it's transference. That's first. The second thing I would do is decide what to do with it. Like, I could actually use that to get the client to do something. Probably wouldn't, but I might be able to. The third thing that I do is confront the client. So now I want to confront the client with, listen, I'm not your sister, or I am not doing what your parents did. I'm here to help you with, that would be direct confrontation. So in transference, process it, decide what to do with it, confront the client. Now, what do you do in countertransference? This is where you're putting emotions or feelings onto the client. Well, in countertransference, what you would do is the first thing you do then is process it. Now, most of the time, and primarily, and most of us agree with this, we believe that countertransference is never helpful and can never be used. And the reason it cannot be used is because it's your stuff, and you're the one who is applying something that doesn't fit, or that may not be appropriate. You're becoming judgmental on a client. So therefore, we would not use countertransference in a positive way. So first thing you do is process it. Second thing you do is work it out. And you can work it out in one of two ways. Run and get your supervisor or seek professional support. But you would never confront the client, not in countertransference. A good way to realize if you're experiencing countertransference is when you find yourself getting angry with a client. If you're getting angry with a client, there's a very good chance that something's wrong with you, because we're here to deliver a professional relationship. And if we're becoming angry, then there's something wrong with the way that we're delivering that. The other thing in terms of transference and countertransference, I want to make sure that you know the difference between transference and job stress, because they are different. Job stress could indeed lead to burnout, and that's usually related to your issues, overall issues. When we talk about countertransference, we're talking about a therapeutic setting or a therapeutic relationship. That's countertransference. So we're looking at a therapeutic setting or a therapeutic relationship. That's countertransference. So a good example then of the difference between job stress and countertransference. If you ever see a question and it says something to the effect of, a social worker works in domestic violence. She continues to work with her clients who often go back to abusive situations. The social worker does not want to go to work because she knows that she's going to see a client and eventually that client will go back. This is an example of A, countertransference, B, transference, or C, job stress. If there's no therapeutic relationship, well, we know it's not transference because it's coming from the therapist. But if there's no therapeutic relationship, it's not countertransference. It would have to be job stress. Now, what if you saw a question like this? A social worker is working with a client in a session, and the client states that she's not sure that she can leave. The social worker begins to feel angry with the client because she believes this client is going to return, like the client that she worked with before. This is an example of, and that would be countertransference, not job stress, because it involves the therapeutic relationship. Make sure you know the difference between those. In terms of social learning theory, in social learning theory, we're looking at the work of Al Bandura in terms of social learning theory. And he talked a lot about learning that takes place through observation and reinforcement. And that reinforcement is the key to continuing behavior. And feedback and self-evaluative behavior is very, very important in terms of how people maintain behaviors. And the rule is that the easiest way sometimes to start a behavior is something called continuous reinforcement. But if you want to maintain a behavior, continuous reinforcement doesn't work as well as something called intermittent reinforcement. Intermittent reinforcement, if you think of the slot machines in Vegas, where you win once and then what do you do with all your nickels or quarters? You put them back in because you just literally became rewarded that one time, and it's such a powerful addiction. In terms of some of the areas, specificity, where things are clearly and concretely identified, successive approximations, where you take small steps to reach a goal, modeling. Modeling is more than just imitating. Modeling is where complex learning takes place. That's modeling. And what they say, modeling is so strong in human growth and development that they often use the term that we marry our mothers and fathers, meaning that the traits of your parents or the traits of those significant role models will come out in you and will show in you. That's why very often in therapy, if you've worked with a client, let's say the method of discipline that you use is spanking, and you're supposed to teach them time out. If their parents spanked, and they have always spanked as a method of discipline, it's extremely difficult to introduce time out, because time out requires a whole new way of thinking and relooking at things. Also, if you have been someone who has been raised with time out, you would perceive spanking as extremely barbaric, and that has to be changed because of your social learning or your modeling behavior. And yet it may not be offensive to someone else. So that's that whole idea of we marry our mothers and fathers, the significance of those role models. They also say that opposites would not attract, and they wouldn't because of the social learning. For example, if I work with a woman, let's say that that woman is married to somebody who's an alcoholic, and she was raised, an individual, we really shouldn't use the word alcoholic, an individual with an alcohol problem, and she was raised in an environment where that exists as well. All right, so she was there as well. Now she marries an individual who has a problem with alcohol. What had I better be careful when I get her out? She'll very often marry another one because they end up in that type of a learned behavioral sense. Performance is where you actually complete the behavior and it becomes more ingrained. In classical conditioning, I want you to know the difference between classical and operant conditioning. Classical conditioning is the work of Pavlov, and that was the reflex, where remember the dog and the salivation and the bell ringing, where they actually rang the bell and gave the dog the meat powder. And then what happened is whenever the dog heard the bell ring, he would salivate for the meat powder. It's a reflex reaction. Operant conditioning, on the other hand, is much more pronounced, and the emphasis is on the consequence, what comes after the fact. That's operant. And if you think about B.F. Skinner, when he had the Skinner box, what he did was he taught the rats to press the lever, get the reward. So they got the reward after the consequence. Most of the treatment that we use with adults is operant related. It's based on behaviors and consequences. And so we see a lot more operant conditioning in our field than we see classical. In terms of behavior mod and changing to behavior modification, what I always say is I try to put behavior modification on a continuum. So what you're looking at one end of the continuum is you have something called applied behavioral analysis. So you have applied behavioral analysis. This is the work of B.F. Skinner. On the other end, you have more of a cognitive behavioral approach. And this is more the work of Aaron Beck, Volpe, people like Albert Ellis. They're on this end of the continuum. On this end, applied behavioral analysis, you have people like Skinner. And I remember very clearly what Skinner said. Skinner said something to the effect of, knowledge is behavior. Behavior is knowledge. Therefore, if it does not exist through behavior, does not exist. So what Skinner was saying in applied behavioral analysis is if it doesn't exist through behavior, it doesn't exist. And so we truly have to not so much worry about what somebody's thinking, but how they behave. On the other hand, in cognitive behavioral, the emphasis is still on the outcome, which is the behavior, but it's the thought that leads to the behavior. They would say we're thinking creatures. I'll never forget, I worked with a woman who bit her nails. This is a perfect example of applied behavioral analysis. She bit her nails continually. They sent her in. They said, you got to do something. I don't know how to help her. You got to help her. I went to the store and bought a bottle of Sally Hansen Bite Your Nails No More stuff. Put it on her nails. She put it in her mouth. Tastes terrible. Took out. Within 2 weeks, she stopped biting her nails. Now, I did not basically do anything to control her thoughts. What I did was got her to stop biting her nails. That stopped her, and she did. So I didn't address the thoughts. Now, there are some techniques that we use today that would use applied behavioral analysis. Some other techniques might be if I'm working with a client who has an alcohol problem and I give them the medicine Antabuse. If they drink, they'll get sick. So they learn very quickly, don't drink, because you don't want to get sick. That would be a good example of applied behavioral analysis. Another example, and this is actually a bad, why the cognitive behavioral people say, but wait a minute, it's more than just addressing the behavior. You have to address the thought that leads the behavior. I remember when they first started talking about chemical castration as a punishment for people who commit rape. What they said was what we could do if, let's say, for example, a woman is raped, we could use chemical castration on the rapist, and that would be the punishment. And so therefore, because he couldn't get an erection, then he could not rape this woman. And that makes sense as applied behavioral analysis. But what they found was that rape is truly not a sexual crime. It's very much tied into, or solely sexual, it's tied into power and control. So what would happen is if they could no longer get an erection to physically rape the person, they might kill them. Because we're not addressing the thoughts that go along with it, the feelings of power, the feelings of control that go with it. So those are cognitive behavioral and applied behavioral analysis. I also want to make sure that you're familiar with reinforcement, punishment, negative, and positive. And you've got a few different things in your book, or a few different ways of looking at these in the book. But what I'd like you to remember in terms of these is when you approach a question that has this in the book, I'd like you to go to the answers first and then work your way back to the question. So remember what the words mean and then work your way backwards. And for example, what I would do is on your scrap paper, I'd like you to write the word positive and negative. And remember what these words mean. Positive means to add something. Negative means to subtract. That's all that it means, add and subtract. Reinforcement means to get a behavior to increase. Punishment or consequence means to get a behavior to decrease. If you see the word reinforcer, be very careful. Reinforcer is not the same thing as reinforcement. Reinforcer has to do with the process. Reinforcement has to do with the outcome behavior. We get it to increase. Where the reinforcer, you support or strengthen the behavior. You can support it, it's the process. You can support it, you can withdraw it. But it has to do with the process of the behavior. Now let's review a sample test question. It says, a client is receiving treatment at an inpatient rehabilitation facility for an alcohol problem and is given the medication Antabuse. When the client takes his first drink, he reacts by vomiting and states that he will never drink again. In this example, the medication is a... Now, what I'd like you to do, go through the answers quickly. Positive reinforcer, negative stimulus, positive development. Go to the scrap paper and work backwards on this question. So, if it's a positive reinforcer, what does that mean? What does that answer mean? Well, positive simply means to add something to the process. A positive reinforcer is where you're adding something to the process. Then it gives you negative reinforcer. A negative reinforcer is where you're taking something away from the process. You're taking it away from the process. What is negative stimulus? Well, a negative stimulus really doesn't fit in this concept. It's more of a distractor. It's a behavior modification term, but it really doesn't fit. A negative stimulus is just something that it takes away or you don't like it. You know, that's a negative stimulus. A positive development really doesn't make sense. So I say it's between A and B. Now go backwards. Go to the question. What are the key words in the question? Client is receiving treatment, alcohol problem, Antabuse. What is the medicine? What is the medicine? They're asking you, what is the medicine? Is it a positive reinforcer or a negative reinforcer? Well, what are you doing? What is the medicine? You're adding a medicine to the process. You're not subtracting a medicine to the process. So the answer would be positive reinforcer. It's important in these questions to work backwards. That's what you want to do. You want to work backwards. Now, what if the answer said positive reinforcement and negative punishment? Then what would you do? Or positive punishment. Go back in and remember what the words mean. Positive means to add something. Punishment actually means behavior decrease. So in this case, the medicine would actually be a positive punishment because you're adding something to get the behavior to decrease. Please don't think about punishment as a negative, like a spanking punishment. Punishment simply means to get the behavior to decrease. Rational emotive therapy. Rational emotive therapy is the work of Albert Ellis. And basically, he is the one who said, don't use words like should. And very often he would insert the curse word into that, okay? And he said, don't use words like must because you masturbate. He is the one who said to really watch the words that you use. And one thing that you always want to be careful of that he talked about is something called catastrophizing. 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 Catastrophizing is where an individual will have something happen to them and they think of the worst possible thing that could happen. The worst possible thing that could happen. That's how you catastrophize. Many of us, for example, if you go in and fail this test, you catastrophize and say, I'm not a good social worker, everybody's going to think I'm stupid or whatever, when really the worst thing that could happen is if you fail the test is you have to take it again. Maybe you don't eat out for a week because you have to take it again, but that's catastrophizing and everybody does it. In terms of the problem-solving models, let me do them quickly for you. In terms of the problem solving, the way that I think about them is I think about, let's start on a continuum again. Let's go back to the 1950s. And we had people such as Helen Harris Perlman. And what Perlman did is that problem solving model. So we've got the original problem solving back in the 1950s. And what Helen Harris Perlman said is she divided it up into the process, the place, the people, looking at all the different P's. If we had a 60-minute session back in the 1950s, I say you would probably spend 55 minutes defining the problem and about 5 minutes wrapping it up. Now, time has moved on, and individuals like William J. Reed have created models such as the task-centered model. And this is in the 1970s. The pressure is on to evaluate things, to make sure that things are evaluated well. We're into the 1970s. So now, that same 60-minute session, I've got 30 minutes to define the problem and about 30 minutes to set up the tasks for solving the problem. Now time moves on and I'm into the 1990s and I'm actually looking at something called solution focused. Solution focused. Now in solution focused, what the emphasis is on is the solution, change talk, and change strategy. That's solution focused. And now that same 60-minute session in the 1990s, we're looking at maybe 5 minutes to define the problem. Where's the rest spent? On the solutions. So we're looking at 55 minutes or so being dedicated to change talk, change strategy, and what you're going to do about it. Now be careful with this model. And the reason you want to be careful, look at it. If you spend all of your time and energy into finding solutions for a problem, what had you better do? You had better define the problem properly and the complete problem. Because if you don't, you've just spent 55 minutes blowing smoke. And that's why if you get an incomplete problem, you may have a wonderful strategy that works great, but the client ends up back into your service again. So we always want to watch that and that connection. In terms of brief plan treatment, people want it, agencies want it. It's very important, and they actually say that 80% will drop out by the 6th session anyway. What I believe that we do is pretty much intermittent therapy. Intermittent therapy is where you do what you can while you can, and every session is usually considered a complete. So you would address termination in each one.
because if that's the only session you have to make sure that you open and close each one instead of having a plan set. But in planned short-term treatment, you just discuss termination in the beginning, in the very beginning. You start talking about termination and how many sessions that you have. Eclecticism or pluralism is where you use a technique that's focused in research or that is very much involved in looking at research. I remember Joel Fisher's book in 1978, where he really started to talk about eclectic practice. And that means using what works based in an empirical base or an evidence-based practice, and then applying that to speed and effectiveness. So using what works and doing it as quickly as possible. In crisis intervention, always remember, in crisis intervention, it's usually time limited. And basically in crisis intervention, you're very active and directive. Active and directive. And in crisis intervention, it's very important to remember that most people are healthy individuals. When they enter a crisis, may do unhealthy things. So our role then becomes to help them balance out. Also in therapy, they say you can never change values, but there is. There's one time in therapy that you can, and it's very often during a crisis, because the usual ways of coping don't work. Some examples of how to apply crisis intervention. If you think of a hazardous event, the hazardous event is the event that occurs to an individual. That's the actual thing. Could be the death of a loved one. The vulnerable state. The vulnerable state is where the individual's usual ways of coping don't work, and so they start to go in and look at other ways. In the vulnerable state, you may see somebody start drinking to self-medicate. That's your vulnerable state. It's a very uncomfortable state. The next level is the precipitating factor. They sometimes call that the last straw. The precipitating factor is very often the thing that pushes the individual over the edge. It could be as simple as a good morning or as a hello. The next one is the active crisis state. And remember, that's when values can be changed, and that's when you need to be very active and directive. Active and directive, always in the active crisis state. And by the way, if somebody is in an active crisis state, don't send them to a group. They don't belong in a group. They need individual therapy. And then eventually they say, with or without your help, that individual will reintegrate and reach equilibrium. And that's the key. You want that person to reintegrate and reach equilibrium. What we bring to this development is that we can help people to reach a healthier equilibrium. In terms of crisis intervention, remember immediate intervention, action-oriented, limited goals, stay in the here and now, focus on resolution of a particular problem, build self-image and self-reliance. In terms of group work in the field of social work has always been and always will be a cornerstone of what we do. We believe strongly in group work. We have certain groups, and again, there's different definitions, but a social conversation group, these are groups where individuals work together. And very often, if you're using an interdisciplinary team or a multidisciplinary team, you'll have what they call a social conversation group, where individuals share. If you have socialization groups, the object is to achieve socially responsible behavior. Education groups can be larger than therapy groups because they are handled in a different way. Also, in a therapy group, most of the time what you want to do is sit, because you want to exchange and feel comfortable working with an individual. Where in an education group, you might stand, because you want to be able to take control and to send a message that you're trying to educate someone, or you're trying to take a teaching role.
Some of the other groups you can go ahead and read through. Probably the most important guidelines in setting up a group is to make sure you introduce yourself first, always, because you set the level of self-disclosure that occurs in a group. You also need to tell the group up front that things that are said in the group will stay in the group. However, remember, these are not professionals, and technically they could violate the group norms. So if someone does violate a group norm, like they start yelling in group or they start talking about somebody outside of the group, what the social worker would do is bring the responsibility back to the group. You've got to bring it back to the group and make them responsible. In terms of sample test questions that you can look at, there are sample test questions provided in your book. What I'd like you to do is what we've been doing. Go through each of the sample test questions as listed in your book. Highlight the key words within the question. Then highlight the key words within the answer. Then go back and make your decisions. Always remember, because particularly in the long case scenarios, it's very easy to get lost with what the question is asking. So I want you to continually practice the sample test questions, because that's going to help you. Get it down to the 4 choices, then you get it down to 2 choices, then you make your best decision. Thank you.